Bueno, bienvenidos a todos a esta segunda mesa del tercer Symposium Internacional de Enfermedades Autoinmunes y Pulmón. Si la primera mesa ha sido muy enriquecedora, yo creo que esta segunda mesa aún lo va a ser más. De hecho, se dedica al tema específico, digamos, del Symposium, que es esto de New Directions in Connective Tissue Diseases, Interstitial Lung Diseases. Me vais a permitir que haga un comentario antes, y es que quiero dar muchas gracias a los organizadores, a Jacobo y a Fernanda, por permitirme moderar la mesa con María. Sí, la verdad es que pasamos horas en la segunda de urgencias, muchas penurias. Y en fin, también. ¿Quién nos iba a decir a nosotros que después de tantos años, ¿no?, estaríamos aquí moderando una mesa precisamente de enfermedades autoinmunes y de intersticio pulmonar, ¿no? O sea que muchísimas gracias, y para mí es un placer comoderar la mesa con María. Bueno, nada, sin más enrollos, la mesa se ha dividido en tres charlas sobre tres temas, digamos, que yo creo que marcan un poquito lo que puede ser el tratamiento de la enfermedad pulmonar intersticial en las enfermedades autoinmunes en el futuro. La primera mesa versa sobre la enfermedad pulmonar intersticial en esclerosis sistémica, una de las enfermedades autoinmunes en las cuales el intersticio predomina y es uno de los principales factores relacionados con la mortalidad en estos pacientes. Y para ello tenemos a Carmen Pilar Simeón. Carmen Pilar Simeón, además de ser una excelente internista, también es una muy amiga nuestra. Ella es internista, trabaja en la unidad de enfermedades autoinmunes del Servicio de Medicina Interna del Hospital Vall d'Hebron, y yo diría que es la referente en esclerosis sistémica a nivel nacional, por supuesto, y a nivel también internacional. De hecho, se formó junto al doctor Vicent Fonollosa y ahora pues continúa, digamos, un poquito la línea de esclerosis sistémica en el Hospital Vall d'Hebron, y ha sido la coordinadora del RESCLE y ahora es la coordinadora, digamos, del RESCLE+ en la Sociedad Española de enfermedades autoinmunes multidisciplinar. Y de hecho, gracias precisamente a este registro, yo creo que hemos conocido mucho mejor la enfermedad, al menos en lo que hace referencia a nuestro ámbito. Ella nos hablará de nuevos retos en el tratamiento de la enfermedad pulmonar intersticial, esclerosis sistémica, con muchas novedades que ha habido, sobre todo a nivel del tratamiento en esta enfermedad en los últimos meses. Carmen, muchas gracias y cuando quieras.
Buenos días. Muchas gracias por la presentación. Gracias por tus palabras. Ha dicho que éramos amigos. Aquí hay varios de los motivos para entender su presentación. El tema que me propuso Gerard fue el de los nuevos retos en el tratamiento de la EPI en la esclerosis sistémica, pero permítanme que antes haga una pequeña introducción para saber qué implicaciones tiene la esclerodermia en el campo de la EPI y qué implicaciones tiene la EPI en el campo de la esclerodermia. Lo primero es saber que la esclerodermia es de todas las EAs, de todas las enfermedades autoinmunes sistémicas, la que con mayor frecuencia puede presentar una EPI. Pero además, si se hacen estudios del SIR en poblaciones generales, comparándolo por edad y por sexo, la esclerodermia tiene un riesgo de casi 180 veces mayor que la población de su misma edad y sexo. Pero además, la EPI puede ser la primera manifestación o la más predominante, y nos podemos encontrar con este subtipo de esclerodermia que existe, que no tiene esclerosis cutánea, que tiene Raynaud, que tiene anticuerpos antinucleares y que tiene una afección visceral típica de esclerodermia. Y la segunda en frecuencia es la enfermedad pulmonar intersticial, que puede afectar casi al 40% de los pacientes con esta entidad. Y en esta línea, la colaboración con los neumólogos es importantísima porque en el Vall d'Hebron aproximadamente un 20% de los pacientes nuevos que se envían a la consulta monográfica de esclerodermia han sido diagnosticados por nuestros compañeros de neumología. Y están diagnosticados aunque no cumplan los criterios de clasificación. Como ha dicho el doctor Selva, los criterios de esa clasificación sirven sobre todo para homogeneizar poblaciones y para hacer ensayos. Este subtipo de la esclerodermia sin esclerosis cutánea cumplen los criterios de clasificación un 40%, pero no por eso dejaremos de hacer el diagnóstico clínico. Por ejemplo, esta paciente, ¿no?, una mujer de 50 años, tiene Raynaud, no tiene esclerosis, hipomotilidad esofágica, tiene EPI. tiene unos ANAs, pero ninguno de los que ponen los criterios, y la capilaroscopia sí que la tiene. Pero sumamos y nos sale 9, no tiene una esclerodermia. Y en cambio puede tener un IPAZ porque sí que cumple los criterios. Defiendo mucho el IPAZ porque es una manera de detectar estos pacientes con enfermedades autoinmunes y que detectan los neumólogos. No cumplirá criterios de clasificación, pero la diagnosticaremos de esclerodermia sin esclerosis cutánea. Pero además, esta entidad es la segunda en riesgo de desarrollar una fibrosis pulmonar progresiva. Si nos atenemos a los criterios del INVIL, el 33% de los pacientes con esclerodermia bien estudiados, que aquí tenemos todos los del Censis, desarrollan fibrosis pulmonar progresiva con los criterios del INVIL. Y en este esquema que ya se ha presentado previamente, pues la esclerodermia está en segundo, tercer lugar después de la FOB y paralela a la neumonitis por hipersensibilidad en riesgo de presentar altos porcentajes de enfermedad pulmonar progresiva o fibrosis pulmonar progresiva. Ante esta situación, también hay que decir que dentro de lo que es la esclerodermia, la IP tiene una importante implicación en el pronóstico, porque es la primera causa de muerte en la mayoría de las cohortes, como lo es en el registro RESCLE, y por supuesto es un factor independiente asociado a mala supervivencia y a un peor pronóstico. E incluso el doctor Rubio, que realizó un modelo puntuado para predecir en el momento del diagnóstico la mortalidad del paciente a los 15 años, por supuesto, la EPI era una de las que más puntuaba de manera negativa. Por suerte, y es el último punto, ante este escenario tengo que decir también que la esclerodermia es la que está mejor estudiada en el contexto de EPI y de la que disponemos de más estudios con evidencia científica. Y como ejemplo, si hacen una búsqueda en el PubMed, fíjense que realmente cómo ha evolucionado, ¿no?, el interés por el tratamiento de esta patología en la esclerodermia, de manera que el año pasado casi 200 artículos, lo que llevamos de año casi 100 artículos. Y esto es porque en base a estos estudios pioneros, ensayos que han demostrado eficacia en determinados tratamientos en la esclerodermia y que solamente disponemos de estos estudios de todas las EAs en la esclerodermia. Y los nuevos retos en el tratamiento no solamente son en el tratamiento, sino que también tenemos que valorar qué nuevos retos hay en otras áreas de la enfermedad, contando con la EPI, en el cribado, en los factores pronósticos, en la clasificación. Y empezando por el cribado, es lo más fácil. El cribado, mejor que diagnóstico, el cribado en el paciente asintomático se tiene que realizar a todos los pacientes que se diagnostiquen con esclerodermia, a todos. ¿Y cómo? Con un TACAR, a todos, no solamente con las PFRs. Si hacemos solamente PFRs, perderemos la oportunidad de diagnosticar EPIs mínimas, EPIs subclínicas. Y así se ha llegado a este acuerdo de consenso europeo en el que participa Alfredo Guillén, que es de la unidad, que se tiene que realizar a todos, el TACAR de inicio, y a todos los subtipos. Y no solamente a la esclerodefinida, de difusa, limitada y SINE, que tiene porcentajes altos de EPI, la difusa un 70%, sino a estos pacientes que diagnosticamos de preesclerodermia, que tienen Raynaud, ANAS o alteración de la capilaroscopia. No tenemos que conformarnos con una anamnesis, hay que hacer un TACAR, porque puede cambiar el diagnóstico y pasar de ser una preesclero o una esclero inicial a ser una esclero SINE, y ya veremos a lo largo del tiempo cómo evoluciona. Por lo tanto, todos los pacientes tienen que hacerse un TACAR en la primera visita, se les tiene que pedir. Y aún así tenemos un reto, porque pueden pensar esto debe estar ya súper sabido y extendido. Pues no. Es una comunicación que van a publicarla ahora en el Clinical Experimental del grupo de Florencia, de Cosimo Bruni. Solamente el 65% de los pacientes, de los médicos que visitan pacientes con esclerodermia, en el artículo pone expertos, solicitan TACAR. Solamente el 65%. Seguimos estando mal. Es un artículo reciente que todavía no está ni publicado. Factores pronósticos, importantísimos. Hay unos factores de riesgo que se asocian más a EPI en el contexto de la esclerodermia: el sexo, la etnia, los pacientes con subtipo difusa, de corta evolución. Y hay otros biomarcadores, porque los anticuerpos en definitiva son también biomarcadores que se asocian también al mayor riesgo de desarrollo de enfermedad pulmonar intersticial. Y hay otros que son protectores, como es la presencia del centrómero o como que este TAC de inicio que he insistido en que se tiene que hacer no tenga nada de patrón intersticial visualizado por el doctor Sánchez, sin duda, para que sea seguro que no hay patrón intersticial. Y en cuanto a estos anticuerpos, aparte de la importancia que tiene porque se asocian más a EPI, son también predictores de progresión. Hace ya unos cuantos años el doctor Guillén realizó un estudio que fue parte de su tesis en el que valoramos pacientes con esclero, EPI, y unos tenían ATA y otros tenían PMSCL. Ha salido en la mesa anterior, ¿no? Y veíamos que los del PMSCL evolucionaban de una manera mejor. Y eso lo confirmamos con este estudio, valorando que la supervivencia libre de EPI grave, definida por FVCs por debajo del 50% del valor esperado. Fíjense qué diferencias tan importantes entre las dos curvas. Y más recientemente pudimos realizar un estudio con la cohorte, una cohorte italiana de Milán, en determinando el anti-RNPC3 u 11 u 12, que por suerte es poco frecuente en la esclerodermia. Es difícil de determinar, solamente lo determinamos por la técnica que ha dicho la doctora Estíbaliz Ruiz por PEMAT, que todavía no está comercializado. Y fíjense también qué diferencias en las curvas de supervivencia libre de EPI grave. Por lo tanto, es un marcador realmente de mal pronóstico, no solamente de EPI. Pero hay otros también parámetros que se relacionan con la progresión. Son parámetros espirométricos y hallazgos radiológicos. Vayamos primero con los hallazgos espirométricos. El grupo de Brompton ha estudiado muchísimo la EPI en la esclerodermia, mucho. Y este es uno de los artículos del año 2017 en que realizó un estudio de supervivencia y vio que las caídas de la FVC superiores al 10% del valor relativo o de entre 5 y un 9 más caídas de DLCO superiores al 15%, estaban claramente relacionadas con un peor pronóstico. Por lo tanto, los tenemos que considerar factores de progresión. Y este artículo muy reciente del CHES, en este artículo valoran el grupo de estudio de los estudios SLS1 y SLS2. SLS1 es ciclofosfamida, SLS2 ciclo versus micofenolato. Pues han analizado en los pacientes que tenían el TAC hecho y que tenían un seguimiento, unos de 12 años y otro de 8 años, han analizado cómo evolucionó este TAC en los primeros años, en el primer año y a los 24 meses, porque el SLS2 duraba 24 meses. Han hecho un estudio multivariable y han encontrado como factor independiente asociado a mortalidad el que haya aumentado en el primer año o en el segundo en el SLS2 más del 2% de la extensión. Por lo tanto, tenemos otro factor de progresión asociado a un mal pronóstico de supervivencia. Pero realmente ¿podemos saber cómo va la progresión en la vida real, en la esclerodermia? Este estudio basado en el registro EUSTAR y publicado hace poquito, pues vieron que estos pacientes con EPI y esclerodermia al año hay un 27% que cae más de un 5% y a los 5 años un 37%. Pero fíjense en las líneas, cómo las trayectorias son muy diferentes. Y más aún, este concepto que teníamos, bueno, cuando pasan 5 años del inicio de la enfermedad no progresan. Pues también con el registro EUSTAR, con un número muy importante de pacientes, han dividido en 4 grupos dependiendo del tiempo transcurrido desde el inicio de la esclerodermia, considerando inicio también el fenómeno de Raynaud, y ven que realmente las caídas en la FVC se mantienen durante todos los años, hasta 15 años después del diagnóstico. ¿Qué reto tenemos aquí? Pues que tenemos que estudiar mejor y definir mejor los biomarcadores y también, sin duda, también el patrón radiológico de inicio. Y quizá pues intentar hacer estos análisis de clústeres, ¿no?, para realizar grupos, poder definir grupos que tengan una misma trayectoria. En cuanto a la clasificación de la EPI, en 2008 fue un antes y un después del estudio y del tratamiento de la EPI en la esclerodermia. Y de nuevo el grupo de Brompton nos lo solucionaron y pues propusieron un esquema simple. muy simple para lo que viene después, ¿eh? En este esquema simple, que basado en su cohorte de pacientes con esclerodermia, alrededor de unos 360 pacientes, estudio de supervivencia y definieron los factores pronósticos. ¿Qué factores pronósticos? Sencillísimo, bueno, sencillísimo. Extensión del TAC, del patrón intersticial, sea el tipo que sea. Si es más de un 20%, es una enfermedad extensa, tienes que empezar tratamiento. O si no dispones del TAC, FVCs por debajo del 70% del valor esperado, también es una enfermedad extensa. Si la extensión es menor del 20% y FVCs por encima del 70%, enfermedad limitada, tienes que hacer seguimiento y hacer respiro cada 4 meses. Si hay caídas de más del 10%, en ese momento pues hay que empezar tratamiento o bien añadir o cambiar el tratamiento. Y esto, con todos los análisis que se han hecho de estos estudios tan importantes como el Sensis, el del Focus, el del tocilizumab y incluso la vida real, pues ha cambiado un poco, porque esta EPI limitada resulta que también progresa. Y esto lo vemos en los subanálisis del Sensis, que casi una cuarta parte de los pacientes con EPI limitada progresan. En el del tocilizumab, que son difusas y con factores de riesgo, con reactantes de fase aguda, también una cuarta parte progresan. Y en la vida real, como en la cohorte de Noruega, que tienen un número importante de pacientes, la mera presencia de EPI empeora la supervivencia y la mortalidad estandarizada. Tenga la extensión que tenga. Cuanto más extensión, la supervivencia es peor, pero las EPIs limitadas tienen una supervivencia del 63% a los 5 años y si en cambio las escleros sin EPIs, la supervivencia es del 83%. Y fíjense el SMR es 5 veces mayor que la población general conteniendo EPI limitada. Y en cambio, la esclero sin EPI es de 2,2. Por lo tanto, insisto, la mera presencia de EPI puede empeorar, o al menos en este estudio y en otros, empeora el pronóstico. Entonces, con todos estos subanálisis ha habido grupos, como el de Michigan, muy potente, el grupo de Cana, en que ha hecho varias propuestas de reclasificar esta EPI asociada a esclerodermia. Y ya les puedo decir, como ven, que el esquema no es tan simple, ¿eh? El esquema no es tan simple y se basan primero en características de la EPI basales y hacen una división que llaman EPI subclínica cuando están asintomáticos y cuando se diagnostica por el cribaje, ¿no? Son los asintomáticos. Y con una extensión que es mínima del TACAR, menos del 10%, y que tienen FVCs, tienen valores funcionales normales y estables. Y en cambio la EPI clínica, condición sine qua non es que tienen que estar sintomáticos o que la EPI impacte en la calidad de vida. Y uno de los siguientes, EPI limitada o extensa, da igual, los valores funcionales alterados o caída significativa de FVC. Además de esto, para iniciar tratamiento, valoran si tienen factores de riesgo de progresión. Y los factores de riesgo de progresión que ellos incluyen es la esclerodifusa temprana, reactantes de fase aguda y o ATA. Bueno, pues vamos a analizar, vamos a ver el Sensis, que es el que tiene más pacientes, más de 600 pacientes con esclerodermia, que su análisis se han realizado. Este es de un artículo recientemente publicado, en el que los pacientes que estaban en el Sensis, el 30% no tenían disnea y tenían características espirométricas y por extensión del TAC igual que los que tenían disnea. Y en cambio, ¿no? Si tú no los tratas, en los que no tienen disnea, también baja la FVC. Por lo tanto, estos pacientes que no tienen disnea, si no entran en la clasificación de epiclínica, ya no los vas a tratar. Entonces, por eso que creemos que este concepto de epiclínica y subclínica no se tiene que implementar y que tenemos que valorar otros parámetros. Y en la vida real, pues también la cohorte noruega lo comunicaron hace poco en la ERS, el 42% de los pacientes con EPI y esclero tienen una EPI subclínica y aún así progresan. Vayamos a otro factor de riesgo, la presencia de antitopoisomerasa 1 o SCL70. No hay diferencias en los 4 grupos, ¿no? Pero aquí vemos que los ATA negativos, cuando les das el tratamiento, también bajan menos. Y fíjense en la reducción relativa, un 61%, incluso más que los que tienen ATA. Por lo tanto, aunque no tengan ATA, otros factores deben de tener que también condicionan el riesgo, ¿no? Por lo tanto, pongámoslo en duda. El ATA sí, pero no solamente ATA. Igual tenemos que valorar más factores de riesgo. Este ya es un artículo publicado, también un subanálisis del Sensis, diferencias entre limitada y difusa. Aquí sí que las diferencias en cuanto a las caídas, la reducción con los que tratan es más importante que en las escleros cutáneas, limitadas, cutáneas limitadas, pero también en las cutáneas limitadas la caída es más importante si no las tratas. O sea que esto lo vamos a mantener, ¿no? Las difusas realmente son pacientes que tienen más riesgo de desarrollar una EPI progresiva. Este ya es un subanálisis que se ha comunicado en el Leular de este año, muy interesante, en el que comparan toda la cohorte del Sensis con pacientes que tienen menos de 18 meses de evolución del fenómeno de un primer síntoma no reinó, que tienen reactantes de fase aguda, que tienen induración cutánea importante, y la verdad es que todos los que tienen estos factores progresan y tienen caídas más significativas de la FVC que la cohorte global. Y cuando se centran, por lo tanto, son factores que tenemos que considerar como factores de riesgo de progresión. Y cuando se centran solo en el grupo de difusa, todavía más. Las difusas que tienen corta evolución y que tienen reactantes de fase aguda y que tienen Rodnan alto, es decir, una induración cutánea más extensa, van peor y tienen más caída de la FVC que los que no las tienen. Por lo tanto, ¿qué podemos hacer para mejorar la clasificación? Pues igual realizar un modelo ponderado, ¿no? Para cuantificar el riesgo de los factores de progresión, definir también los factores de riesgo de progresión en el grupo de la EPI limitada. Y lo ideal sería pues, hacer un subanálisis dentro del grupo de escleros difusas, de los que llevan en tratamiento con micofenolato, unas empeorarán, micofenolato solo, y otras no, con el nintedanib. Intentar identificar factores de riesgo de progresión en los pacientes que llevan el tratamiento con micofenolato. Y también lo ideal sería, conforme pasan más años, hacer análisis de supervivencia como los que han hecho los de SLS1 y SLS2. Pasamos a las recomendaciones terapéuticas. Vamos a las guías del Eustar 2017. ¿Qué recomiendan para el tratamiento de la EPI asociada a esclerodermia? Recomiendan ciclofosfamida con un nivel de evidencia alto, en base a dos estudios que los dos se publicaron en el 2006. El primero se publicó en el New England, ciclofosfamida oral durante un año. Oral, cuando se sabe todos los efectos adversos. La diferencia entre un grupo tratado y no era de 2,53%. Y además, a partir de los 18 meses y en los 24 ya no había diferencias. Claro, la ciclofosfamida no se puede mantener in eternum, por lo tanto, poco valor. Pero la P le salió significativa, New England. Segundo estudio, también del grupo inglés, del grupo del Royal Free, también muy potente. Ellos utilizaron ciclofosfamida endovenosa, mucho más lógico, durante 6 meses y después pasaron hacia teoprina. La diferencia entre uno y otro era mayor que el del 2,53, era 4,19, pero la P no le salió significativa, total, una artritis, que también está bien, pero no fue un New England. Pero yo vengo a decir que realmente cuando ves trabajos en grandes revistas tienes que analizarlos porque no siempre son el paradigma y tienes que seguirlos, ¿Cuál es la experiencia nuestra? No nos esperamos, ¿no? Gerard y yo no nos esperamos al año 2006 a que saliese a no tratar ningún paciente, ¿no? Teníamos que hacer algo. Al menos en Vallebrón, pues yo seguía a los que llevaban lupus y empecé a poner tratamiento con ciclofosfamida endovenosa, con el esquema de la nefritis lúpica, y desde el año 2000 al 2006 tratamos 16 pacientes. Poníamos el tratamiento durante 2 años y las 2/3 partes estaban estables, que lo valorábamos en ese momento por FVCs que no cayesen más de un 10%, y claro, después retirábamos el ciclo. ¿Y qué ocurría? No les poníamos nada más, y entonces a los 24 meses efectivamente el paciente empeoraba. Entonces era cuando teníamos que o volver a poner bolus de ciclofosfamida, siempre intentando no pasarnos de 15 gramos, o bien en ese momento hacia teoprina. Cuando pudimos realizar el trabajo conjunto con los pacientes que estaban controlados aquí en el Hospital Clinic en el año 2011, pues también tuvimos los mismos resultados. Había una estabilidad de la CVF. Tengo que decir que en los dos trabajos también se cuantificó la extensión por TAC, que lo hizo Esther Pallisa, y no había diferencias. Se hicieron TACs, estos sí que se hicieron TACs cada 6 meses y no había diferencias. Problema de la ciclo, efectos adversos y las dosis acumuladas. Por suerte, en el año 2009 ya había unos cuantos estudios que habían utilizado micofenolato en cohortes pequeñas y que veían que realmente, además de mejorar, en algunos había estudios de supervivencia, como el de Londres, el del 2007, veían que las FVC se mantenían, todo un éxito. Esto ya se consideraba un éxito terapéutico, el que se mantengan. Nosotros empezamos a utilizar también el micofenolato pues alrededor del año 2008 y los primeros 14 pacientes que pudimos tratar con micofenolato sódico porque se tolera mejor, interfiere menos con los IBPs, a dosis de 720 cada 12, recalco esta dosis. Y vimos también que casi un 80% pues, estaban estables a lo largo del seguimiento. Micofenolato, el SLS2 que les comentaba antes, es este trabajo que se publicó en el año 2016. También se publicó en el Lancet Respiratory Medicine y comparan micofenolato 2 años con ciclofosfamida 1 año. Y ven que la eficacia en relación a la FVC es igual, pero se tolera mucho mejor el micofenolato. De hecho, la ciclofosfamida se tuvo que interrumpir casi en el 50% de los pacientes. Por lo tanto, aunque no esté aprobado el micofenolato para esta indicación, el micofenolato es el fármaco que más se utiliza y que está en todas las recomendaciones, en revisiones hechas de expertos para la EPI asociada a esclerodermia. Sigamos con rituximab. Recientemente se ha publicado un ensayo a doble ciego con rituximab, con un esquema como el del linfoma, más que el que realizamos por AR o nosotros. Y poquitos pacientes, el objetivo primario era la induración cutánea, pero también como secundario tenían el seguimiento de la FVC. La diferencia entre el grupo tratado y no era de casi 3%, que se detecta a partir de las 12 semanas y que la P también les ha salido significativa. El rituximab es un buen fármaco también para el tratamiento de la EPI. Llegamos al tocilizumab. El ensayo del tocilizumab, que se llama FocusCET, incluían solo pacientes con difusa, de menos de 60 meses de duración, con un Rodnan importante y que tuviesen algún criterio de inflamación, que tuviesen al menos PCR alta, BSG o plaquetas elevadas. Y no se permitía que los pacientes llevasen ningún tratamiento inmunosupresor. Tenían que venir solo para integrar con el tocilizumab. ¿Cuáles han sido los resultados del tocilizumab? Pues el objetivo principal era la piel. No le salió. El Rodnan no se modificó de manera significativa. Pero, en cambio, en el grupo de pacientes que tenían EPI, que eran 136 pacientes, en estos se vio que la caída de la FVC en los pacientes tratados era menor que en los que no se trataban, con una diferencia de un 4,5. Pero la verdad es que las caídas significativas de más del 10%, no tratado 25%, tratado 8,5%. Y, por lo tanto, se ha aprobado por la FDA para la EPI asociada a la esclerodermia sin tener en cuenta el perfil del paciente en general, sea difusa, sea limitada o sea SINE. Pero hay que tener en cuenta el perfil. En el 2016 ya se empezó a hablar, ¿no?, de las nuevas estrategias, ¿no?, del tratamiento antifibrótico. Y estas nuevas estrategias ya han llegado. Estamos ya en el año 2022 y el nintedanib, que es el antifibrótico que se ha aprobado tanto por la FDA, por la EMA como la INS para tratar la EPI asociada a la esclerodermia, pues se publicó ya hace unos 3 años y es un ensayo que ha recogido un número de pacientes inmensurable. No hay ningún estudio con este número de pacientes, 288 tratados, 288 placebo. Con unas características basales, pues la mitad son difusas, la duración de la enfermedad puede variar entre 4 y 6 años o 7 años. La mitad llevaban micofenolato. Esto es la vida real. ¿Por qué? Porque utilizamos micofenolato cuando hay EPI. Por lo tanto, es un estudio que recoge pacientes de la vida real. En cuanto a las características de la EPI, pues la verdad es que la extensión era importante y la FVC media no está mal, por encima del 70%. Resultados, pues igual que pasó con la FPI, los enfermos tratados tienen una tasa anual de descenso de la FVC menor que los pacientes no tratados, con una reducción relativa del 44%. Los que tienen NINTE, la caída es 1,4% y los que tienen placebo, 2,6%. Como ven, sobre todo, es más notable a partir de las 12 semanas las diferencias. Análisis de los pacientes que están con micofenolato. Ya sé que no se pueden comparar entre ellas, pero ¿cuál es el que cae menos? Pues el que lleva micofenolato y lleva NINTE. O sea que esta combinación parece que está indicada, ¿no?, aunque no haya este análisis, ¿no?, de comparar uno y otro. Creo que es un resultado importante y que precisamente estos pacientes con NINTE y con micofenolato son los que tienen un porcentaje de progresión menor, ¿no? Considerando la FVC de caídas de 3,3% del predicho, del esperado, que se considera la clínicamente significativa. En cuanto al nintedanib, ¿qué experiencia tenemos nosotros en el servicio en la unidad de enfermedades autoinmunes sistémicas? Pues tenemos 22 pacientes en nintedanib, muchos vienen del ensayo Sensis y del Sensis On, otros les hemos puesto off-label solicitándolos. Desde el verano no podemos poner ninguno porque no está financiado y no se aprueban. Las características pues son menos difusas, quizá, muchos con micofenolato, casi el 80% con micofenolato. Características de la EPI, pues también muy parecidas, más o menos, el 29% de extensión, FVC un poco más baja que el del Sensis. ¿Qué resultados tenemos? Hemos hecho un estudio para saber la progresión según criterios del GO, que es este del 10% o 5 y 9 y del LCO del 15%, el del INVIL o las nuevas del ATS, y como era esperable, pues con las nuevas, ¿no? Pues tenemos mayor porcentaje de pacientes que cumplen criterios de fibrosis pulmonar progresiva. ¿Qué retos tenemos aquí? Hay que actualizar las guías y las recomendaciones. También se podría proponer realizar estudios comparando monoterapia con terapia combinada desde el inicio, bien con NINTE o bien con tocilizumab, comparándolo con micofenolato o combinados. En cuanto al algoritmo de tratamiento y de seguimiento, hemos dicho que este era el algoritmo que nosotros utilizábamos hasta el año 2020, ¿no? Un algoritmo sencillo que utilizábamos cuando eran extensas, poníamos micofenolato y si empeoraban, pues añadíamos rituximab y si había una situación adversa o no toleraba micofenolato, ciclofosfamida. Este es el esquema que proponen los expertos de Michigan y otros expertos también. Como ven, no es lo mismo. Y además siguen insistiendo en dividir la epiclínica y subclínica. Yo creo que esto lo tenemos que descartar porque si no se va a favorecer el que se piense que solamente tienes que tratar cuando hay disnea o cuando hay una implicación en la calidad de vida, y no es así porque llegaremos tarde y lo importante es llegar lo antes posible. ¿Cuál es el esquema nuestro ahora que hemos modificado? Epiextensión más del 10%, tratamos, son los que entraban en el Sensis. Cuando es menor del 10%, pero mayor al 5%, y si tienen factores de riesgo de progresión, los que sabemos que siguen siendo validados por los diferentes estudios, los tratamos, y también los ATA. Y si no hay factores de riesgo de progresión, ahora esto ya nosotros no los vamos a tratar, aunque puede haber muchos interrogantes, porque como hemos dicho, la mera presencia de extensión que sea puede marcar el pronóstico. Entonces, estos pacientes, si no los tratamos, les hacemos controles espirométricos cada 6 meses durante 3 años y los que sí que tratamos cada 3 o 4 meses. Si se detecta y que empezamos el tratamiento cuando tienen más de un 10%, ácido micofenólico, como les he comentado, y el dato que les tengo que decir es que si con 720 cada 12 no hay buena respuesta, aumentamos para hacer 3 gramos al día del micofenolato de mofetilo, que es el equivalente, que es el que utilizaron en el SLS2. Se utilizaron 3 gramos, pero lo hacemos de manera progresiva. Es muy importante titular los fármacos para la buena tolerancia. Si con 720 cada 12 funciona y no hay caídas, mantengamos esta dosis. Si en esta situación del micofenolato, un paciente que tiene una difusa y tiene reactantes de fase aguda, en los controles cae espirométricamente, le añadimos tocilizumab. Y en este caso, si a pesar de añadir tocilizumab sigue cayendo, le añadimos nintedanib. Tenemos 2 casos así. En caso de que sea una limitada y que no tenga estos factores de reactantes de fase aguda, no sea una difusa de corta evolución, cae con micofenolato, le añadimos directamente el nintedanib y tampoco empezamos a dosis plenas, empezamos con 100 miligramos día y vamos aumentando cada 4 días. En caso de que no vayan bien y que siga habiendo caída, siguiendo el esquema de GO, 10% entre el 5 y un 9 y del LCO por debajo del 15%, porque como las escleros pueden hacer también vasculopatía, la del LCO del 10 igual es un poquito justa, hacemos un poco más, la del LCO del 15%, pues añadimos rituxi. Tengo que decir que en esta época de pandemia no hemos puesto ninguno por el riesgo del rituxi en la situación de COVID, o bien tocilizumab. En caso de que haya efectos adversos con el micofenolato o con alguno de los anteriores, ciclofosfamida. Hace 15 años que no utilizamos ciclofosfamida endovenosa. Y si hay una insuficiencia respiratoria grave, pues valorar para trasplante pulmonar. trasplante pulmonar que también se puede hacer en los pacientes con esclerodermia. Los centros trasplantólogos muchas veces cuando ven que el paciente tiene esclerodermia ya lo rechazan. Se pueden trasplantar. Se pueden trasplantar porque hemos visto en la unidad del Vallebrón que los trasplantan y que tienen evoluciones similares a los pacientes que no tienen esclero, de supervivencia. Y un poquito más largo incluso, pues las supervivencias siguen siendo buenas, a los 5 años de 60%. Por lo tanto, estos nuevos retos, ¿cómo los podemos simplificar? Aparte de saber que esta EPI es frecuente y que marca el pronóstico de la enfermedad, tenemos que hacer el cribaje en todos los pacientes para una detección precoz. Tenemos que intentar definir bien los factores de riesgo y que sean validados y que ampliados. La clasificación de EPI ahora está en proceso de cambio y seguirá cambiando probablemente conforme salgan saliendo más subanálisis, pero tenemos que ser más exigentes y bajar el dintel de la extensión, porque el tratamiento debe ser precoz para evitar la progresión y para preservar la función respiratoria, porque los neumólogos saben que no, que cuando ya está establecido es difícil retrogradar. Y el algoritmo de tratamiento se basa pues, en las características basales y en los factores de riesgo que conocemos hasta ahora. Muchas gracias.
Muchas gracias, doctora Simeone. Las preguntas las haremos al final de la sesión. Y si os parece, vamos a pasar a la siguiente presentación. The next presentation, I have the pleasure to introduce Elena Margagli from the ILD unit in the respiratory department of Siena. It's a pleasure, Elena, to have you here in this session. She will talk about the pleuroparenchymal fibrolastosis, which is a recent entity in ILD and a very interesting one. Thank you, Elena.
Thank you so much, Maria, and thank you to Jacobo and to everyone. So it's a great pleasure to be with you, and I was really fascinated from previous presentation, and so I realized that your experience in interstitial lung disease, also as a rheumatologist as well as a pulmonologist, is really very high. So it's a great pleasure to discuss about a new entity that is called PPFE. So I hope to receive my slide, otherwise I will share with you. Okay.
¿Al equipo técnico? Vale.
So I will share with you, so I hope that you can see. Maria, can you see?
Yes. Now you have to open the screen.
Yes. Okay.
Now perfect, Elena.
Yeah, thank you so much, Maria. So I'm going to discuss with you about a new entity that is something that is probably is occurring in your clinical practice also very recently, according to the recent guidelines of interstitial lung disease. So PPFE is a rare new entity of interstitial lung disorder that sometimes can occur also in association with rheumatology lung diseases. So PPFE is characterized by fibrotic thickening of a visceral pleura and subadjacent parenchymal areas of the upper lobes. So it's a disease that mainly involves the upper lobes of the lungs. So you have to take care and to pay attention to the upper lobes of the lungs in which the disease generally starts. So pleuroparenchymal fibroelastosis is generally associated with a progressive involvement of the lower lungs, and histologically is characterized by the presence of elastosis. So elastosis is something that occurs in this disease, and it's something that makes a very different radiological appearance of this interstitial lung disease compared with, for example, other interstitial lung disorder. Radiological feature generally is detected by CT scan. So it's sometimes possible to see by chest X-ray also alteration of the upper lobes, but the golden standard for the diagnosis is absolutely a high resolution computed tomography of the chest. So the radiological alteration occurring in this disease are generally pleural and subpleural fibrotic thickening with upper lobe predominance and traction bronchiectasis. So the architectural distortion of disease is really very evident in the CT scan with loss of volume and reticulation. Very nice, interesting thing is pleuroparenchymal fibroelastosis can be present in the idiopathic or can be sometimes associated with other diseases. It was first discovered associated, for example, with drug-induced interstitial lung toxicity, but we know that can be also described in a rare variant of idiopathic form. The disease can be sometimes also associated with lung transplant, for example, or bone marrow transplant, or sometimes can also occur in other organ transplantation. It can be observed also after treatment with oncological drugs, as well as in association with immunosuppressive treatment. Sometimes can be described also in patients exposed to silicate dust or asbestos, and so it can be discovered also in patients with occupational exposure. Moreover, more recently, it has been very clearly demonstrated an association of PPFE in patients with recurrent lower respiratory tract infection. So in patients that can have, for example, immunodeficit, can be observed the frequent respiratory infection, we can observe PPFE. So probably a persistent and repeated inflammatory stimuli can induce this kind of interstitial lung alteration occurring mainly in the upper lobes. The disease may be associated with different radiological pattern of interstitial lung disease, and sometimes it has been reported that associated with no specific interstitial pneumonia, and generally is particularly associated with rheumatological disorder, including rheumatoid arthritis or systemic sclerosis, but can also be described in association with other interstitial lung disease, for example, in patients with fibrotic hypersensitivity pneumonitis. And the symptoms of this disease are absolutely specific. And so we can have a dry cough, we can have sometimes a weight loss, or moreover, exertional dyspnea, that is generally the most common symptom. And the cough can be described as a very dry and recurrent cough that sometimes occur in this patient, and that can sometimes be associated with an acute symptom that can be pneumothorax. As you can see, the fibrotic alteration can induce pneumothorax very frequently. Sometimes it has been also reported PPFE in association with familiar form of connective tissue lung diseases or interstitial lung diseases. It seems that it's much more frequent in female than male, suggesting probably a genetic predisposition that can probably make a role in the development and susceptibility of this disease. When all these conditions are excluded, so we can exclude an autoimmunity, or we can exclude, for example, an occupational exposure or exposure to different drugs, we can make the diagnosis of idiopathic PPFE. And that is generally a negative diagnosis, in the sense that the prognosis can be very poor. And in this case, in 8 to 10 years, the patient generally require lung transplantation, as we don't have a specific treatment for this kind of interstitial lung disease. It's really very relevant to observe the pathological, the histopathological alteration occurring in this rare interstitial lung disease that are mainly associated with aggregates of elastic fiber, especially in subpleural areas, and intraalveolar collagen deposition with septal elastosis. So elastosis is something that generally is associated with a PPFE, and in something that makes the difference with other interstitial lung disorder. Very recently, we described PPFE also in other rare interstitial lung disorder, for example, in arteritis and vasculitis. And sometimes we don't know if the presence of pleuroparenchymal fibroelastosis can be a simple coincidence or a novel phenotype of a disease. And is also what is happening, for example, for connective tissue ILD, in which, for example, for systemic sclerosis, but also for other rare vasculitis, PPFE can be observed sometimes in more than 20% of patients. So we don't know exactly the clinical meanings of the association, but it's obviously commonly reported that the presence of PPFE in the upper lungs is associated with a negative prognosis. So this patient generally have a progressive disease, can show a progressive deterioration of lung function parameters and also a progressive deterioration of a CT scan. More recently, we describe a rare variant of idiopathic PPFE associated with the presence of non-necrotizing granulomas. So it's very rare to find this kind of elastosis or fibroelastosis in patients with a granulomatous lung disease, very similar to sarcoidosis. So there are no evidence of PPFE, for example, in other granulomatous lung diseases, and also in sarcoidosis, we have just a single case report. So probably we need to obtain much more information about the association of PPFE with granulomatous lung diseases. So just to discuss with you the relevance of this new entity and of this evidence of the radiological and histological features of disease occurring, for example, in connective tissue disease, as we need to collect much more data to understand the prognosis of our patient and the natural history of this rare variant of interstitial lung disease. So we don't have a specific treatment, we don't have a specific biomarker to detect the prognosis of this patient and also to define the diagnosis. So we recently performed a sort of three-decision algorithm to define the role, for example, of KL6 in the specific disease and to define the prognostic role of the association of KL6 with lung function test parameters in this patient. So we hope to find the novel biomarkers, we hope to find a way to define the prognosis of our patients according to the association of different biomarkers in this patient. And we can see that the association of FBC, KL6 and other lung function parameters can help to monitor this disease and also to evaluate the prognostic evolution of our patients. So we have done that study in association with the rheumatology unit in Florence with Professor Matucci-Cerenic to identify the role of KL6 in patients with systemic sclerosis and interstitial lung disease. And we found that the KL6 associated with the LCO, FBC, and FEV1 can improve the specificity and the sensitivity of our biomarkers to predict the outcome of our patients. So I have to thank you, and really great thanks you to give me the opportunity to stay with you today. And thank you, Maria, for the help.
Thank you, Lena.
So I'm so sorry because I don't know if you have some questions because I have to leave to another conference. So I don't know, I cannot stay.
Don't worry, Elena. we will open if you want. We will open the questions for you now. Even we have 10 minutes until Jelmi Edema starts. So we have time for your questions now.
Thank you, Maria.
Don't worry, Elena. You will have one question from Jacobo.
Viene aquí, Jacobo.
Ciao, Jacobo.
Hey.
Nice to see you.
Nice to see you, Elena. I don't know if you see me. I don't know. Yeah. Anyway.
I can see you. Yes, I'm here.
Okay, so thank you very much for being in the conference. We are starting to use KL6, and I am seeing that you have some experience in fibroblastosis. But my question is, it's very practical. In your experience, what you consider a clinical important change in KL6? What's your impression of, for example, you increase 500, you increase 1,000? Because it's something that I have some doubts, and I don't have this clinical point. And I haven't seen very much numbers in your data, but it could be in fibroblastosis, but in others. What's your experience, or what's your point of the clinical relevant change in KL6 for you?
Thank you so much, Jacobo. What's a great question. So, as you know, in different interstitial lung disease, KL6 concentration have been evaluated. So we have different cutoff values for different interstitial lung disease, mainly in non-specific interstitial pneumonia. For example, in fibrotic HP, it has been recognized this cutoff value as greater than 480 as a parameter to differentiate high value and low level and low concentration of KL6. But what it seems very irrelevant and very important is not the concentration in a single moment of a history of our patient, but the evolution of a KL6 level. So it's important to make specific measurement of KL6 at different stage of a disease, because probably it's not the value itself that it has really relevance, but the evolution in time, in accordance, for example, with treatment. As you know, Francesco Bonella published it very recently also together with us. So the serial measurement of KL6 as a prognostic value, as a prognostic parameter to define the evolution, for example, of IPF in response to anti-fibrotic therapy. So it seems that not only the single value at the onset of disease or the diagnosis that can have a prognostic value, but the serial measurement during the follow-up of our patient. So the increased concentration of KL6 in a patient treated, for example, with anti-fibrotic drugs may suggest a progressive disease, for example. While if you have a stable concentration of KL6 in the follow-up, generally you have a stable disease and not a progressive fibrotic disease.
Thank you. And I have another fast question. Do you treat fibrosis or not? Or
Oh, that's a great question. So if you have an idiopathic PPFE that is quite rare, but it can occur, generally the treatment of PPFE is the treatment of a disease associated with PPFE. If you have an idiopathic form of PPFE, unfortunately, we don't have a specific treatment, but we can, in some cases, suggest anti-fibrotic therapy. As you know, PPFE has been included in the clinical trials, but unfortunately, the treatment with anti-fibrotic drugs seems to be not so effective in this subpopulation of patients. The problem of PPFE is so rare in the idiopathic form that you have so few and limited data, not only on KL6 concentration, but also on the natural history of the disease, because sometimes it can be misdiagnosed and can be also confused, for example, with pleural cup, that it seems the answer to a specific, for example, infection such as TB, a previous TB. So we have a big problem of the need of, and really urgent need of further research on PPFE and KL6 and on PPFE and the answer to treatment.
The last question. I'm Dr. Gerard Espinosa. Nice to meet you, Dr. Bargagli. Given the high specificity of CT image of PPF, do you perform biopsy in all patients?
Oh, that's another great question, because the problem of PPFE is that it starts from the peripheral areas of the lungs. So if you do a biopsy through bronchoscopy, it's really very hard to arrive on the peripheral areas of the lungs. So sometimes you have a high risk of pneumothorax, as you can imagine, because you have to arrive really near the pleural areas. So sometimes you can have some problems with the biopsy because of a pneumothorax that can occur in the majority of these patients. So we have some experience with cryobiopsy, for example, but in cryobiopsy can do the diagnosis of pleuroparenchymal fibrolastosis, but it's clear that the position and the place in which this disease appears is so peripheral that can be also at high risk of pneumothorax. So we do biopsy only in really very limited case, for example, when we have a suspicious of idiopathic PPFE.
Mm-hmm. Thank you very much.
Thank you, Elena. May I ask you a last question? It's
Yes.
a practical one, because it's one clinical doubt that I always have. We have some PPFE patients with respiratory bronchiolitis. I don't know if you have the same experience, because it's not described, and they have more dyspnea.
Yeah, and that could be really a great topic, Maria, to put together also these patients in a database in which we need to understand the evolution of this patient. So PPFE can be the answer to a persistent infection, for example. As you know, bronchiolitis and respiratory bronchiolitis can be associated with persistent infection in the lungs. So perhaps PPFE is a sort of answer to the persistent infection that you can have in this patient. But we have also a subgroup of patients with bronchiolitis and PPFE. So we need absolutely to put together this data to understand if it's just a coincidence or if is really a different phenotype of respiratory bronchiolitis. We have an increased number of patients in the last 2 or 3 years with respiratory bronchiolitis. I don't know in Spain, but in Italy we found a greater number. Probably we are doing much more CT scan, and so we found something that was not so common in the past.
Yes, and also for the with the cryobiopsy, it's easier
Yes.
to. So we will do it, Elena.
Thank you.
Thank you very much. We will do it. Thank you very much,
Ciao.
Elena. And
Salve, ciao, ciao. Have a nice conference.
I hope
Thank
to
you.
get
Thanks,
you.
Jacob.
I hope that the next time you can come in presence here.
Yeah, yes, and not to be in contemporary with the Florence conference.
Bye, Elena.
Ciao Maria, ciao, ciao Jacopo.
Ciao. And for the next presentation, we have the pleasure to have Jelmy Edema. He's an ILD pulmonologist in Erasmus University Hospital in Rotterdam, and it's a pleasure to introduce him. Hi, Jel, do you see us?
Yes, thank you. Thank you for the introduction.
Thank you for participating, and it's the stage is yours.
Thank you. Thank you for the introduction and the kind invitation. So I'm trying to share my screen. Let's see if it works. Do you see my screen now?
Yes.
Yes.
Perfect. So I was asked to talk about progressive fibrosing connective tissue disease related ILDs. So the question is how and when to treat. So this is the subject for the upcoming 30 minutes. And these are my disclosures. So I thought about separating 3 parts in this talk. So first I want to introduce the subject and talk about the heterogeneity of the connective tissue diseases and their ILDs. And second, it's good to discuss something about the progressive pulmonary fibrosis phenotype within the CTD patients, and talk about the new guidelines that we now have that have been published recently about progressive pulmonary fibrosis, or PPF. And in the last part, the third part, we can talk and discuss about anti-fibrotic treatment in progressive pulmonary fibrosis in connective tissue diseases, and say something about the timing of that treatment. And I would like to end with a Dutch statement that we wrote almost 2 years ago now with the Respiratory Society and the Rheumatology Society together as a statement on anti-fibrotic treatment of ILD and progressive fibrosis in connective tissue diseases. So first, in the introduction, as you're probably very well aware of, if you talk about connective tissue disease related ILDs, we talk about a very heterogeneous group. So depending on what kind of investigation has been done and of course the setting of the research, you can find up to 50% of ILD in systemic sclerosis and inflammatory myositis. A little bit less in RA. There's a lot of different reports there. Sjögren's syndrome can be about 2 to 25% of ILD, and in lupus we see it a little bit less. Of course, depending on what kind of modalities are used and the timing of the study that has been done in the past. So if you find ILD in those patients, in CTD patients, it can be an important cause of death, as you're well aware, especially in systemic sclerosis, for instance. And it has important therapeutic and prognostic consequences if you find it. So you need to think about what it means for the patient and how to treat it most properly. And this is just to visually, again, show the heterogeneity about the CTD. So on the left, you have different autoimmune diseases, CTDs. And in the middle, we have the patterns, some of the patterns that we know from a pathology perspective. And I have some CTs, just CTs there, resembling the pathological patterns. So if you talk about rheumatoid arthritis, for instance, the red arrows here point at the patterns that we see most often. It's most URP pattern that we see, but it can also be NSIP, pleural disease, and airway disease. And of course, everything is possible, but we see the other patterns a little bit less. And if we go to systemic lupus erythematosus, it's a little bit different. We have NSIP pattern most often, but also pleural and pericardial disease and vascular problems. And the other patterns are also possible. In systemic sclerosis, you had an update already. We see mostly NSIP patterns and vascular problems, pH, of course, but also microvascular problems. In myopathy, it's a little bit different, mostly NSIP and organizing pneumonia combinations, but the rest is possible. And in Sjögren, you have, well, the NSIP mostly, but also LIP, for instance, and airway diseases. So if we lump all the CTD ILDs together, for instance, in clinical trials, we talk about this group of patients. So it is rather heterogeneous, and it is quite interesting to lump them all together and say something about treatment here. So most of the CTD ILDs are treated, at least in the beginning, with immunomodulatory treatment, and the majority of those treatments are considered sort of an extension of the treatment that you use for the systemic disease itself, so the CTD. And of course, depending on the amount of ILD and the pattern, we usually go to corticosteroids and a steroid-sparing agent, for instance, azathioprine or mycophenolate or cyclophosphamide. And in other diseases, we also use biologicals, actually used for the CTD itself, but it can also stabilize or improve the ILD. But the problem is we really lack robust randomized controlled trials. So evidence is really limited. Outside of systemic sclerosis there, we have some evidence there. And then we have the heterogeneity of the connective tissue diseases, their patterns, their disease behaviors, and the outcomes. So it's rather difficult to design trials to really get data from specific CTD, specific situations. But this is a very nice example of randomized controlled trials that has not been published yet, but discussed on the ATS. I'm very happy to see some of the results already, although we don't have the published information. This was a randomized controlled trial that has been done in connective tissue disease-related ILD. And the primary outcome, or the goal, was actually to show superiority of rituximab over cyclophosphamide in CTD ILD. And here you can see that 50 patients were treated with cyclophosphamide. It was 600 milligrams per square meter for 6 times every month, or rituximab, 1 gram and 1 gram after 2 weeks. And you see that most of the patients that were included were actually inflammatory myositis patients. We have some systemic sclerosis as second category, and the third category was mixed connective tissue disease. So the idea in this trial was to demonstrate superiority of rituximab after 24 weeks, measured by FVC, forced vital capacity. And what was demonstrated was that the forced vital capacity increased in both groups, actually pretty well, about 100 milliliters. So this is actually a negative trial because there was no superiority, but both increased the lung function. It was a small difference of 38 milliliters in favor of cyclophosphamide. And there was an increase in quality of life measured by K-Bill scores. And if you look further on in the trial at 48 weeks, both arms actually increased in FVC more than 100 milliliters. And within the rituximab group, there were less adverse events reported and a little bit more steroid tapering. So this is what we need in CTD ILD. We really are in need of more randomized controlled trials to guide us with what to treat with. But of course, we don't have all the details yet. So it's really important to look at these patients. So they all had more than 4 years of time since disease onset. So how were they treated? What kind of patients were there? Was there any fibrosis or not so much fibrosis? So we need additional data to interpret these findings, but they're highly anticipated on, and it's really nice to see these data coming in. So even just to go a little bit further into the heterogeneity, even within the disease itself, so within inflammatory myopathy, within anti-synthetase syndrome, and within the same antibody, so anti-Jo1 positive, I have 6 patients from my outpatient clinic here with the CTs demonstrated here. So we have 2 patients that are probably very well manageable with corticosteroids and a steroid-sparing agent, while 2 other patients have been progressing towards fibrosis already, but are quite stable on biological treatment with rituximab. And the same disease, different phase, I have 2 patients here that have progressive fibrosis already and are treated with anti-fibrotic therapy. So the heterogeneity also in disease phase and pattern is very clear, even within the same disease type. So this is what we do in the MDTs all the time concerning ILD, but specifically also CTD ILD. So we think about the pattern we see, not only the connective tissue disease itself. We think about what we see. Is it reversible? What kind of pattern is it? Is it acute or subacute? And then we make the treatment decisions with the limited evidence that we have. And we decide on what to treat with. But now we're going to proceed towards the category of patients that we want to discuss. So we have progressive or slowly progressive fibrosis within connective tissue disease patients, despite conventional immunosuppressive therapy. So this is what we're going to talk about. And I think mostly, at least in our center, we would already given rituximab a little bit earlier in the disease phase, I think, especially myositis or RA. But sometimes you can also give it as rescue therapy. And this overview, a really nice overview from 2018, of course, is a few years old. And considering enrollment in anti-fibrotic trial, we already have the data from anti-fibrotic trials, so it would be different right now. So now we can move on to the second part and discuss the progressive fibrotic phenotype within the connective tissue diseases and the guidelines that have now been published to help us guide therapeutic choices here. So does it make sense to treat them all with anti-fibrotic therapy? So here, I must say pathogenesis is still work in progress. So there's a lot we don't know yet. There's a lot we assume, but we now think there's an early phase with very disease-specific pathophysiology of the ILD, shared risk factors, obviously, but different CTDs can have different inflammatory hits, and the ILD that is progressive in the disease itself. But if there's fibrosis in a later stage of the disease, we now think there's some form of self-perpetuating fibrosis. Yeah? So the myofibroblasts are there, they produce extracellular matrix, the lung gets stiffened, hypoxemia is there, there's traction on the, there's traction on the tissue, and it produces its own fibrosis and it gets progressive anyway. So it does, from a pathogenesis perspective, make sense to treat different CTDs with the same kind of treatment. So how big is the problem we're facing here? So within all the ILDs, this is a very nice publication from my colleague, Marlies Wijsenbeek, and she, with all the literature available 2 years ago, she made an estimation about, well, the prevalence of CTD-ILD and the progressive phenotype. So within all the ILDs that we see, that's the left circle, it's about 1 out of 5 that is related to connective tissue diseases. Of course, it can vary depending on the hospital you work in. But if you go to the right circle, which is the CTD itself, you can see that most of the ILDs that are estimated we see is RA and systemic sclerosis. Systemic sclerosis with a lot of ILD, of course, in RA because it's more prevalent. And this is not my personal experience, but about 17% is apparently lupus related. I think it's a little bit less in our hospital, but again, this can be dependent on the hospital, obviously. And the inner figure is the estimation of the fraction of patients with the progressive phenotype. So in RA, it was estimated about 40% of patients and about 1 out of 3 in SSc-ILD. So how do we define progressive pulmonary fibrosis? There have been several trials, several suggestions, and a lot of criteria. But now, very recently, we have an update on the IPF guideline and the progressive pulmonary fibrosis guideline. So this can really help us. And they defined, so the committee defined progressive pulmonary fibrosis, or PPF, as a composite of 2 out of 3 criteria. So the respiratory complaints or symptoms, pulmonary function, and radiology. And it has to be within 1 year follow-up. And of course, very important, it has to have no alternative explanation. So decline in pulmonary function is not, by definition, progressive pulmonary fibrosis. Obviously, you have to look for different reasons. So they defined the 3 criteria as worsening of respiratory symptoms, lung function decline, and radiologic evidence of disease progression. And within lung function decline, they now stated that it's an absolute decline in FVC of 5% or more, which is a little bit different from some other criteria used in the past. And they included DLCO, so diffusion capacity, a decline, absolute decline in 10% or more, meaning you go from 70% predicted to 60% predicted as a patient. So it can be either one of the two. And we now call it PPF, which is different from PF-ILD that has been used in a lot of studies that were published in recent years. So the committee stated that they chose PPF because well, the progression is beyond the interstitial space itself. That makes a lot of sense, I guess, because there's always airways disease and other problems involved. And it produces a trajectory of pulmonary function decline that is similar to IPF. So it makes sense to have IPF and PPF. And the third reason is it's compatible with the term pulmonary fibrosis that has been used all over the globe. So this is a rather new term, PPF. And DLCO is new, comparing to inbuilt criteria, for instance, because it has not been a successful endpoint in clinical trials. It has been very variable between labs, between hospitals, and in between the same patient, because there's the variability of the measurement. But it has been a strong predictor of mortality in patients. So it makes a lot of sense to include it, to select patients at risk for mortality. So if we now have the criteria of PPF, we need data, real-life data, to see how the trajectories are, how are CTD-ILD patients behaving in real life. So this is a very nice and recently published study about a registry, prospective registry actually, from Canada, 8 centers, and they looked at pulmonary function after inclusion in the registry, and they defined progression as a relative FVC decline of 10% or more, or one of two of any FVC decline between 5 and 10, increase in respiratory symptoms, or more fibrosis, and included death and lung transplant as criteria for progression. And what you see here is there's a very large group of CTD-ILD patients included, which is very interesting for the subject here. So more than 900 patients were included with CTD-ILD, mostly systemic sclerosis, but also RA and myositis. And you see that 45% of the patients actually met criteria defining progression, which is a little bit larger than the estimations from previous literature. It is really a big group. That's interesting. And another interesting finding is that about 40% in the whole cohort of CTD-ILD patients was not treated at that time. Could be for several reasons, of course, but so there is a big proportion of patients not treated there. And if you look at the time to progression, so to fulfill the criteria, you see the upper line of the different progressive pulmonary fibrosis patients. That is the CTD-ILD group. And well, the worst one, that is the IPF category. That is the hallmark progressive pulmonary fibrosis patient category. So the time to progression is delayed compared to IPF. We already knew that, but it's been established again in this cohort. And there's another interesting thing. If you look at a different retrospective cohort, also very recently published in the ERG, with a US test cohort of more than 750 patients and a validation cohort in the UK, where they looked at the 1-year FVC change in non-IPF fibrosis, and they looked at different criteria for progression, for what was then called PF-ILD. And they also looked, so whenever you got a PF-ILD criteria, they would look again at another year of FVC decline or trajectory. So that's interesting. You can see here that again, there's a large group of CTD-ILD patients included, more than 300 patients in the test cohort and 184 in the validation cohort. And they analyzed 6 different criteria here that were all stated in different literature. ILD was the most common subtype, and in the overall group, a little bit over 50% was treated with immunosuppressants, and just a small group had anti-fibrotic treatment. That is all the patients from the cohort. And here you see the inclusion. Some patients were excluded because they didn't have any HRCT available or baseline lung function or follow-up lung functions, but still a lot of inclusions in the cohort and the validation cohort. And here you see 3 groups: connective tissue disease ILD, the idiopathic inflammatory incision pneumonia, and the chronic HP. And the upper line is the CTD-ILD group. So you see that the trajectory of the FVC after inclusion, after diagnosis, in the CTD ILD group is really not declining as much as the other groups. Actually, in the first 2 years, it's increasing a little bit. That's very interesting. So what's happening? If you look at the different CTDs in the cohort, that's what they did here. So they looked at myositis, RA, systemic sclerosis, and other. You see that one group stands out. So the myositis is the upper line, actually increasing for a few years. So probably responding pretty well to whatever treatment they've got. And the other groups, the RA, systemic sclerosis, they declined, and they were quite similar in the decline over years. So this is in months after diagnosis. But now they looked at the patients that actually fulfilled a PF, so progressive fibrosis criterion. And these are all the different criteria that they looked at. But now let's look at one of the criteria that's in the new guideline. So 5% decline or more in absolute sense of FVC. And if you then look at the connective tissue disease cohort, that was, well, more than 480 patients, you actually see a small increase in FVC. So I think here, this is because of the large group of myositis patients that might behave a little bit different than the other ones. So now we come to the third and last part of the talk. So we're going to talk about treatment of CTD ILD and then the progressive fibrotic phenotype, the timing of the treatment, and we're going to end with the Dutch statement on treating fibrotic ILD, progressive fibrotic ILD in connective tissue diseases. So you all probably know this trial, the INBUILD trial, landmark trial 2019. Progressive fibrotic lung diseases were included, non-IPF, and you see the criteria here. And they were very good in selecting patients that were progressing in the upcoming year. They were treated with placebo or nintedanib for 52 weeks and looked at FVC, mean change in FVC from baseline. And here you see that the nintedanib treated patients actually had a lot less adjusted annual rate of decline in FVC compared to placebo, over 50% relative decline. So it was the efficacy was good of the treatment. But we are asking things about connective tissue diseases here. So now let's look at the placebo groups in the trial and zoom into the autoimmune related ILD placebo group. That was 88%, or 88 patients. And here you see the decline in 52 weeks of FVC, which is very much comparable to the rest of the group, to the non-IPF ILD group, about 180 milliliters. And you can even compare it with the decline that IPF patients showed in different trials, such as the Impulses. So this really was a group that progressed and showed a sustained decline in FVC. And now let's go further into the INBUILD trial. The post-hoc analysis of the connective tissue diseases have been published very recently. And this is the group, the post-hoc analysis of the CTD ILD patients. And as you can see, most of the patients that were included were RA patients, a little bit over 50%. And you had systemic sclerosis, much less other connective tissue diseases, such as mixed connective tissue disease or maybe even myositis. And about 3/4 of them received immunomodulatory therapy. Most were low-dose corticosteroids that was allowed in the trial. Some had DMARDs and 1 out of 10 had biologicals. I'm not aware of the details of the treatment here, but there were some treatments on background here. And the adverse events were quite similar between the groups. There were a little bit more adverse events leading to discontinuation in the treatment, but that was because of some diarrhea or liver function abnormalities, nothing that we don't know of with nintedanib treatment, so nothing new. And here is the primary outcome. And again, comparing to the whole trial and different other subgroups, you have, well, an effect of nintedanib on the CTD-ILD subgroup that is about half the decline that was seen in the placebo group when you are treated with nintedanib. So 76 milliliters compared to 179 milliliters. And just to be sure that's not one particular connective tissue disease that is skewing the whole result here, of course, these are small numbers, so we have to be really careful with these post hoc analysis, but you can see at least that there's not one connective tissue disease or autoimmune disease that is skewing the whole result. So overall, the result was the same within the different groups that were included. And of course, we have some data for pirfenidone from the RELIEF study, a double-blind, randomized, placebo-controlled trial that included progressive fibrosis. Here you see the inclusion criteria. So progression was a little bit differently defined with an annual decline of FVC of 5% or more. And patients were randomized for pirfenidone or placebo. And the primary endpoint was an absolute difference in FVC predicted from baseline to week 48. But the problem here is there were 127 patients included, of which 37 connective tissue disease related ILDs. But the trial was terminated early because of futility. There was slow recruitment and they had to do some imputations for missing data. And if you then do the primary analysis, well, it favors pirfenidone. Here you see the change in FVC in the pirfenidone and placebo groups. Well, we have to be a little bit careful to interpret these data because of the things that was stated here, but it is at least a suggestion it works. But there were only 37 connective tissue disease patients included. So the group is really small if we look at that specific group here. So we have the guideline. What does it say about progressive pulmonary fibrosis, which you can also apply in the connective tissue disease group now? Well, there is a favor of nintedanib treatment for those patients if they fulfill the criteria of progressive pulmonary fibrosis who failed standard management. So this is important. There has to be standard management that failed. And of course, further research. And there was no evidence-based treatment recommendation on pirfenidone due to lack of, well, robust evidence, but there is a voting issue here because a lot of committee members did not vote because of lack of evidence. And the members that voted in favor of. So there was no evidence-based treatment recommendation here, but it has also to do with the level of evidence and people abstaining from voting here. So what is the right timing from anti-fibrotics? To be honest, we only have the data from the trial. So everything else is an assumption. We're not sure whether treating patient outside of inclusion criteria has efficacy. So we know IPF needs anti-fibrotic treatment from the start, and we know and think connective tissue disease-related ILDs have a more inflammatory phase, or at least can be inflammatory the whole time during the trajectory. But there is a phase with immunomodulatory therapy where it can actually work pretty well. We now start anti-fibrotic therapy as soon as the PPF criteria are met. So what are the knowledge gaps? What do we really need? We need biomarkers to predict PPF before it happens, because you already lost pulmonary function, and we really want to be ahead of that problem. We want less progression here. And you can think of molecular biomarkers, but also maybe something as easy as home monitoring of pulmonary function, where you have more data points. Maybe we can be early with seeing progression there. The next thing is we need to have a trial design assessing efficacy of early antifibrotic therapy. We're just not sure now whether it helps if you start in the more inflammatory phase already, because there's no trial that has been designed to answer that question specifically, outside of systemic sclerosis, where we have a little bit more data. And we really want to know if we need to switch, or we can give a combined immunosuppressing and antifibrotic therapy regime, which is usually the case, at least in our center, that we combine it. So now I'm going to end with the Dutch position paper, which is quite practical because we have a lack of evidence here. So it helps us to make treatment decisions. And the key points here, so this is written by rheumatologists and pulmonologists here in the Netherlands. So we stated that first, treat the connective tissue disease, not only the ILD. So it's a systemic disease, please be aware of that. And of course, the ILD can be the primary focus, but we need to address the other symptoms as well. And the MDT meetings are central in patient care. So we not only discuss upcoming treatment there, but we also evaluate the treatment after several months to learn and to see what works and what doesn't work, because we have a knowledge gap here. So we divided two kind of patients here. We have the ILD patient with an inflammatory or mixed pattern on CT. And in this patient, we optimize the connective tissue disease treatment first, and then we evaluate the pattern as stated before. So we think about an idea how it's going to behave. Is it really steroid responsive, for instance? Is it quite fibrotic? What it's going to do, and how risky is it? Of course, very limited ILD can have a wait and see policy. But if it's not limited and partially reversible, we start with anti-inflammatory or immunomodulatory treatment first, and of course non-pharmacological treatment. And we keep evaluating both those patients every 3 to 6 months. And if you then fulfill the criteria for what we then called PF-ILD, which would now be PPF, I think we should rewrite it, then we go to the next phase. Just assessing the non-pharmacological treatment, there's not only drugs, of course, so these are also very important things to address in CTD-ILD patients. Prevention of smoking, vaccination, physical, psychological treatment, assessing lung transplants, palliative care, all are, of course, very important. But then you fulfill the criteria, which are now PPF criteria. So we should add the DLCO of 10% absolute decline and the FVC 5% or more. So we should change it a little bit, I think. We reevaluate the patient. And then if there's still signs of active CTD or inflammatory pattern on the CT, we change and we switch to second-line anti-inflammatory or immunomodulatory therapy, and we add the anti-fibrotic here. If we really see the connective tissue disease is not active, also evaluated by the rheumatologist, and we have a real fibrotic ILD, we sometimes switch to an anti-fibrotic. But of course, you have to be careful that the systemic symptoms will not become active again. The second group, and this is one of the last slides, is the CTD-ILD patient with just a mere fibrotic pattern on HRCT. And in real life, this is going to be the RA patient with a UAP pattern. So if this presents on your outpatient clinic, we optimize the connective tissue disease treatment, of course. Maybe there's joints that need to be treated and other symptoms. And we give anti-fibrotic treatment as a first-line treatment as well. And of course, the non-pharmacological treatment. And we're going to assess and see. And if there's really limited ILD and no progression risk, we sometimes, have a wait and see policy. And of course, we evaluate and discuss again in the MDT. So to conclude, progressive fibrosis in CTD patients, well, I think you should treat the CTD as a whole, not the ILD, of course. And you should treat always within a multidisciplinary team because of the systemic nature of the disease. And what's new is that the estimated amount of CTD patients that will progress to PPF is rather big. It could be 40, 45%, depending, of course, in what kind of patients you include in cohorts. But it might be a little bit bigger than previously thought. And of course, the FVC decline in PPF patients with connective tissue diseases, it varies. And it might be less pronounced, for instance, in the myositis group, which we maybe should not always lump together with, for instance, RA in trials. And the fourth point is we have the new guidelines, we have PPF criteria now established to select patients with worse prognosis. And this can help us to guide what kind of patients we're going to treat with anti-fibrotics or not. And with this, I would like to end and thank you all for your attention.
Thank you very much, Jel. We will ask Dr. Simeone to come with us for the questions. Thanks, Jel, because it was an extremely perfect summary of something very, very complex.
Thank you.
¿Alguna pregunta en el auditorio?
Yo voy a empezar con una para los dos, Carmen, si os parece. I will ask a question for you and Carmen, because you introduced it very well, the variability of the radiological patterns, and probably depending on this variability, the behavior of the patient and the progression will change or will be different, and even the answer to the treatments. And I like it a lot, your schema, your algorithm, taking into consideration these types or these different fibrotic or non-fibrotic ILD patterns in the clinical practice, how we should start with treatments if the first line for the autoimmune disorder is not working, if we are facing a non-fibrotic ILD patient. Because with the fibrotic one, we have clear that we will go for nintedanib, but in a non-fibrotic or non-predominant fibrotic pattern.
So who's first with the answer? Maybe I will start. It's a very important and very nice question. I think this is the hardest thing we are facing now. So we have a lot of lack of evidence in clinical trials, and then we have a non-fibrotic ILD within a connective tissue disease, and first line is failing. So the only things we have is the small cohorts and a publication that guide us with what might help, and we have our clinical experience. So I think first, to start off with, because of this difficulty, I'm really in favor of clustering these patients into centers as much as possible, so we can increase our knowledge, we can include in clinical trials, but also our personal experience and with these kind of patients, which can be very hard to treat in refractory cases. So what we do is we take into account, of course, the CTD itself. So is it a myositis patient? That would be rather different than, for instance, RA or systemic sclerosis patient. In systemic sclerosis, we have much more evidence for different phases of treatment, as been shown very, very nicely by my colleague. And we take into account what works for the CTD itself. So in myositis, for instance, we have some cohorts stating that rituximab might work very well, and we have our own experience that it actually works pretty well in a lot of the patients. And now we have the first RCT showing that it's quite similar to cyclophosphamide. So in our center, for instance, if you have a refractory myositis patient on mycophenolate and prednisone, we will probably add rituximab pretty soon, especially in the endocentesis. And if a patient is MDA5 positive, we would immediately level up the treatment into triple therapy. So it depends on the CTD itself and your experience, and of course the data that are there. But it's a hard question.
Carmen?
Hard to answer, at least.
Thanks. Carmen?
Lo siento, pero yo hablar en castellano porque
sí,
mi
sí.
inglés es penoso. Y también quiero decir que me he dejado la última diapositiva, que probablemente era la más importante, que era el de agradecer al comité multidisciplinar que tenemos en el Valle Bron, porque las decisiones siempre se toman consensuadas, sobre todo con los antifibróticos. Nosotros empezamos con los inmunomoduladores, pero cuando hay que poner un antifibrótico lo valoramos con radiólogos y con patólogos. La verdad es que patólogos no hacemos biopsias, y con los neumólogos. Y la manera de ponerlo, en la línea también de si el paciente tiene muchas manifestaciones más de la enfermedad, más artritis, utilizábamos rituximab hasta la pandemia, que decidimos utilizarlo lo mínimo posible porque no es una condición de vida o muerte, y por lo tanto hemos hecho muchos cambios de rituxis a ninte y también a tocilizumab. Y si el predominio es de fibrosis, pues sí que entonces empezamos con el ninte. Lo que no sabemos todavía es, si empezamos terapia combinada de inicio, no inicial, ¿no? de inicio pro, no, ya poner los dos fármacos, sino esperar 12 semanas y hacia las 12 semanas no, la FVC baja, entonces añadir el antifibrótico. O sea, una terapia combinada secuencial, porque se tolera mejor, como ocurre un poco con la hipertensión arterial pulmonar, ¿no? Quizá no es necesario de entrada, para mejor tolerancia, pues hacer una terapia secuencial, intentando poner los dos fármacos en los pacientes que tienen factores de riesgo de progresión, y sobre todo si a nivel de radiología se ve NIU o se ve que hay algún factor más, que pues las bronquiectasias, ¿no? Que son datos que te hacen pensar que va a seguir progresando la fibrosis. Gracias.
Jill, I'm Fernanda from Hospital Clinic. Thank you so much for your presentation. Very nice. I have a question, a clinical question. I think that the new criteria for progressive pulmonary fibrosis are pretty clear, but in clinical practice, we have patients with FVC in the limit, maybe 50%. Should we wait 3 or 6 months to say that this patient have a progressive pulmonary fibrosis, or should we treat it like a progressive pulmonary fibrosis at that time?
Thank you. That's a very good, I think, a very important question. Sometimes we have those patients, right? And well, we all think about treating now, I think, and not waiting another. That's a problem with criteria. How much lung function decline are you accepting before you proceed with the criteria? Of course, officially we have the criteria and we have to see what the patient is going to do within 1 year. But I think I would take into account the patient's story here, because, for instance, if it's a myositis patient who has been rather stable and you're just starting up rituximab, you might wait and see what's going to happen. But if the patient has a really fibrotic ILD, has symptoms and characteristic indicating bad prognosis, and you have a story of the patient that is indicating that it's been progressing quite rapidly in a few months, I would rather not wait. Of course, this is a discussion because we have a guideline saying we should, of course, see for another few months. But I would discuss with the patient, we'll incorporate the guideline rules. But if a patient has a really, let's say, a UAP pattern with RA and it's going really fast, and the patient tells me, well, I can barely go upstairs, and this was different a few months ago, I would take that as a definite sign to start treating, yeah, of the guidelines there.
I have 2 questions, one for each speaker. Marcelo Sanchez, radiologist from Hospital Clinic, and I like a lot your algorithm with 2 groups, with the fibrotic pattern in HRCT and inflammatory pattern in HRCT. But I think that you told that the fibrotic pattern was an UIP in rheumatoid arthritis. And I'd like to know what do you think about a fibrotic NSIP or a fibrotic OP? Because I think that fibrotic patterns are not only UIP.
Yeah,
to include in your algorithm these patients.
Yeah. So there's a really great remark. That is why we stated fibrotic and non-fibrotic patterns, and we didn't say UIP and NSIP. So we kept the way we discussed the patterns on CT very broadly into fibrotic and non-fibrotic. So sometimes when you have a patient and you have the characteristics and it's a fibrotic NSIP, but you just see the pattern and you see the connective tissue disease and the patient's disease phase, and you think this is really someone who needs upfront anti-fibrotic therapy here, especially the trajectory there. So I definitely agree that sometimes a really fibrotic NSIP can be a primary fibrotic presentation there, and would scoop into the second category of patients, definitely. Although I must say that, for instance, a fibrotic NSIP limited within a myositis patient with anti-GL1 could also stabilize on other therapy. So we still need to discuss in the MDT what kind of patient it is outside of the pattern, but definitely I agree. Sometimes other patterns can be the second category as well. Yeah.
Thank you. And para la doctora Simeón, he visto que ya os vais a la mini limitada, ¿no? O sea, extensiones del 5% para tratar, que ya no es el 10% de extensión en el TAC, sino que habéis bajado al 5% en los pacientes con factores de riesgo o lo que sea. Y que realmente 5 es muy poquito. Y luego comentar esto. Y luego lo de la progresión, aquel artículo que has sacado, que los que progresan en un año un 2% van peor. O sea, un 2%, a mi ojo, yo no te lo puedo decir, ¿eh? O sea, aquí sí que tendría que utilizar software seguro. ¿Qué opinas?
El 5% lo hemos decidido sobre todo por el análisis del focus set, que en cualquier grado de EPI la pérdida es importante, o sea que realmente es los pacientes que tengan las características del ensayo con tocilizumab, ¿no? Difusas, tempranas, rondan altos, inflamadas. El del 10% es obvio por el Sensis. Y en relación al SLS1, SLS2, que son ensayos muy antiguos, ¿no? Del año 2006 y 2016, es el grupo de Goldman y de Taskin, y ellos dicen que esta valoración lo han hecho visual. Ellos mismos se hacen esta crítica, ¿eh? El aumento del 2% lo han hecho visual y que no es automatizado. Pero han hecho un multivariable incluyendo edad, FVC, y otras características, y como factor pronóstico independiente les ha salido esto, que cuando aumenta más de un 10% la extensión en el SLS1 en un año y en el SLS2 2 años, y valoran la supervivencia a los 8 y a los 12 años, pues les ha salido. No puedo decir nada más. Está publicado recientemente en el CHEST y critican el que no sea automatizado. Esto sí, se hacen una crítica propia, pero consideran que es la manera que lo han valorado ellos.
Sí, no, lo que me sorprende, porque cuando yo he valorado manualmente, a ojo, extensiones, siempre te aproximabas al 5% más cercano, porque no podías ya ir a menos de eso, ¿no? Y por eso me ha sorprendido realmente la referencia de la progresión del 2%, que digamos que cuantificando, yo creo, por software sí que puedes llegar a hacer estos porcentajes visual. Me leeré el paper para ver qué sistema
me interesa mucho tu opinión, la verdad, pero a mí me sorprendió el 2%, pero lo ponen así, sí.
Hombre, yo creo que, siguiendo con lo que dice Marcelo, cuando tú haces una lectura visual del TAC y son más de 2 lectores, hay una variabilidad entre el 1 y el 3% arriba abajo, con lo cual lo que dice él es verdad. Es decir, si ya entre 2 o 3 lectores independientes puede habitualmente haber una variabilidad más o menos entre 1 y 3%, poner el 2% es verdad que es muy difícil.
No os puedo decir más. Ellos la única crítica que hacen es esta, que no es automatizado, sí.
Para rizar el rizo, en el chat nos han preguntado si en pacientes con IPAF utilizáis un esquema de tratamiento similar a los de esclero.
Los pacientes con IPAF los llevan los neumólogos y se comentan en el comité, y dependiendo de si realmente hay muchas características de que van a acabar desarrollando o ya cumplen criterios, podrían ser diagnósticos clínicos de miopatía inflamatoria, se hace el tratamiento que se sugiere por Albert Selva, y si por perfil de anticuerpos o si hay fenómeno de Raynaud, se empieza micofenolato.
There is a question in the chat. The question is, in patients with IPAF, how do you treat them? In the similar way that other CTDs or systemic sclerosis or RI?
Yes, yeah, exactly that. The last remark. So what we do is we mostly we'll look at the criteria. We look at the manifestation there and try to look for the treatment that mostly resembles the criteria that the patient fulfills. So if you have anti-synthetase antibodies and an NSIP pattern, we will probably treat exactly the same as the IIM itself, with most of the time same results. Yeah.
Okay. ¿Más preguntas? ¿Comentarios? Jacobo?
I'm going to do your opinion. I'm Dr. Seyares from Hospital Clinic, and I would like to know about the functional data. Let's change from radiological to function. So my question is, what's your opinion? Because in using absolute or relative changes and 5% or 10%, I thought that in your Dutch guidelines, you said absolute change, or it was absolute change in capacity in forced vital capacity? It was not relative. It's not like, because the INBUILD trial is relative, but the new guidelines is absolute. And also your opinion if it has to be 1 year or 2 years as the INBUILD in contrast with the guidelines. Your personal opinion.
Yes, thank you. Thank you for the question. A really nice one as well. So we made it very easy for ourselves. So we did not define absolute or relative. So with the upcoming guidelines and whatever was coming, we just said between 5 and 10%, and the other criteria are above 10, and we could just fill in whether that would be absolute or relative. It's making ourselves easy, of course, in the paper there, but it was written 2 years ago. So I would suggest committing to the new PPF guideline just to make a uniform policy here. That was the whole idea of the position paper in the first place in the Netherlands, to make sure with the lack of evidence, we at least would do about the same with the same patients all over the country. So now with the new guidelines, my personal opinion would be committing to the new PPF guideline as much as possible. So taking the absolute decline of 5% or more of FVC and 10% DLCO as a long-term criteria, and within 1 year, as the statement or the new guideline states. But that's just a personal opinion, of course.
Yeah.
¿Más comentarios? Para la doctora Simeón o para el doctor Midbada.
¿Más preguntas? Yes. ¿No? Ha sido un amago de pregunta por allí.
Jill, I guess that we are on Friday, July 1st, so people is trying to go fast, and they are hungry because here in Spain it's quite the time for the lunch, but even now I guess that it's the first time that we finish before time, 15 minutes before time, so very well organized, Jacobo. Because it's an achievement, especially in Spain, Jill. So thank you very much for your time and your presentation. It was a pleasure to see you and to hear your excellent talk. Thank you.
Thank you so much.
Thank you very much.
Have a nice talk.
¿Cierras tú, Jacobo?
Sí, pues muchas gracias a todos y tengo muy buenas noticias porque la comida está preparada y está fuera. O sea que podemos ir antes sin problemas.